Nairobi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Nairobi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Nairobi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Nairobi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Nairobi Hospitals is a completely paperless and filmless hospital. The Nairobi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Nairobi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of fragrance of care. The hospital is 475 bedded with a 25% critical care bed count. Nairobi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Nairobi Hospitals is more than a hospital. It is an experience.
Good morning and a warm welcome to all the panelists and all those who have joined in on a Sunday morning for this edition of the Wellness Series presented by the Hindu and the Nairobi Hospital's Vellore. Today's discussion is on an extremely important topic of obstructive sleep apnea and how can we get our night's sleep back. As we grow old, don't we all often wish we could sleep like a baby? We all understand that getting adequate and sound sleep is essential for maintaining our optimal health and well-being. Sleep, in fact, is told, is as vital as eating a balanced diet and doing regular exercise. But our modern day living and working conditions often do not always allow us to embrace a good quality sleep. And add to it these days our obsession of staying awake on the social media. Given our lifestyles and health issues, sleep apnea creeps in as a potentially serious sleep disorder. And there are three types of sleep apnea: obstructive, central, and complex. Over the next 1 hour, our panelists will focus on obstructive sleep apnea as it is one of the most common forms that requires doctors' intervention. I would like to invite first Dr. T.V. Rajagopal, who completed his MD in pulmonary medicine from King George's Medical University, Lucknow. And he's presently the consultant in interventional pulmonology in Nairobi Hospital's Vellore. He is the sleep physician who has established the level 1 polysomnography labs at the Nairobi hospitals. And he will explain to us what is obstructive sleep apnea and why do we need to diagnose it for our own benefit. So a very warm welcome to you, Dr. Rajagopal, and over to you.
Is the screen visible to others?
Yes, it is.
Yeah. Good morning, everyone. So, as you can see on the screen, why is a cat sleeping there is because when we think of sleep, cats sleep about 2/3 of their lifetime, whereas humans just requires 1/3 of their lifetime. But even then, we should get that good night's sleep to be productive for the remaining lifetime. So going ahead. So this is how our talk will be going on. Like, why is the sleep important to us? And effects of sleep deprivation. Why does a patient snore? Symptoms of obstructive sleep apnea. And risk factors of obstructive sleep apnea and its complications. And how common is OSA? Why should we deal about it in our day-to-day practice? So why is sleep important? Sleep is actually, it's an active state. Though we assume it to be a very passive state, it is actually an active state where our brain helps in memory consolidation, emotional regulation happens during the sleep. Cellular restoration like repair and the balance gets restored. And hunger regulation, which is very important from the OSA point of view. And heart BP regulation, which is also a very important part. So overall, sleep brings in balance to all the bodily functions and including the mental well-being of a person. So what happens when a person gets sleep deprived? It can be either acute, where we are prone to work for around 24 to 36 hours continuously, which is an acute sleep deprivation. Whereas a chronic sleep deprivation is like every day we lose like 1 or 2 hours of sleep and gets accumulated over time. The main consequences include like mental health disorders become more prevalent in sleep deprived persons, immune dysfunction, diabetes mellitus, heart diseases. Obesity is more prevalent in patients who are chronically sleep deprived, hormone imbalances like thyroid diseases, and also chronic pain. So coming to the discussion of this OSA, just a minute. Okay, so we should know like why does the patient snore? To understand that, we should go into a bit of anatomy of throat. I'll make it as simple as possible. As you can see here, air usually passes through the nose, which is the nasal cavity, then enters behind the throat. That is the space where we call as pharynx, then enters the trachea, which we call as windpipe. So this is the oral cavity where air can also pass through the oral cavity behind the tongue into the same passage and enters into the trachea. The most narrowest part, as you can see on this picture, is this area which we call as pharynx. The important structures which we need to understand is genioglossus is the muscle of tongue, which is the main muscle of tongue, which prevents this tongue falling back and closing up the airway. The other minor muscles include geniohyoid, mylohyoid, which are less important. So as you can see, it's a common passage between the nasal cavity as well as the oral cavity into the pharynx, and then it divides into a windpipe, and the behind one is the foot pipe. So we are more concerned about air getting blocked here in this area, which is called the pharyngeal area. So this is, though it looks very difficult to understand, I'll make it very simple. Like, for example, this is the air passage, as you can see. Ignore the numbers which are written there. This brown one is the muscles which I told, which helps in keeping the airway open. So as you can see, normally this has to be like a rigid tube where air is able to pass very freely from one end to the other end without any obstruction. Whereas when we sleep, normally for every patient, the muscle's tone gets lost, which means the ability to keep it open is slightly reduced during sleep. For some people, it is partially reduced, which we call as hypopnea, which means the airflow is partially reduced, but not completely blocked. The next step would be a complete block of airflow into the tubes, which is called an apnea. Apnea in medical terms is like cessation of breathing, which means the patient stops breathing for at least 10 seconds and more, which is called as an apnea, which is caused by an obstruction. So it is called obstructive sleep apnea, especially it happens during the sleep. And then once it is blocked, our brain gets aroused so that the pharyngeal muscles are all stimulated so that the airway gets open again. This process of from partial to complete narrowing and then the patient gets awake gets repeated over time, like multiple times during a single night. So the patient's sleep gets fragmented, which we
Doctor, your audio is giving some problem, I think.
call as a fragment.
Windpipe and into your lung.
Yes, ma'am. Just a minute.
Your audio was not clear in the middle.
Okay, then I'll explain, ma'am. Not a problem.
Just towards the end of that slide.
Okay, sure. Is it visible? Is it audible now?
Yeah, yes. It
Travels down your throat, through your windpipe, and into your lungs. The narrowest part of that pathway is in the back of your throat. When you're awake, muscles keep that pathway relatively wide open. But when you sleep, those muscles relax, allowing the opening to narrow. The air passing through this narrowed opening may cause the throat to vibrate. That causes snoring, which many people experience. But in some people, the throat closes so much that enough air can't get through to the lungs. When this happens, the brain sends an alarm to open the airway. Most often, this is associated with a brief arousal from sleep. The brain quickly reactivates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This disorder is called obstructive sleep apnea.
So now we know why an obstructive sleep apneic episode happens. We need to know what are the symptoms usually the patient presents with. The first and foremost will be a disturbed sleep, and the patient might complain of choking episodes at night, which may be even looking like the patient is gasping for his breath, which in turn leads to unrefreshing sleep in the morning. Then daytime sleepiness. Patient may not be aware of the initial symptoms, but the patient will have an unexplained sleepiness during the day. They'll be falling asleep in inappropriate places like at work, while they work in front of the system, or while watching a TV, they just sleep off. The third one will be a daytime fatigue, which is unexplained, and trouble concentrating with work, especially which needs very strict attention. And the other important symptom would be nocturia, which means like frequent urination at nights. And the most common symptom which everyone presents with is a loud snoring. Now we need to know what are the risk factors of OSA. There are certain risk factors which we need to be aware that needs. Foremost would be an obese patient. Obesity is one of the main risk factors for obstructive sleep apnea, and males are generally prone for the same symptom. And increasing age, like the prevalence of obstructive sleep apnea increases steadily when the patient ages. And the surgically correctable ones are like anatomic abnormality, like a large tonsil, or you would have heard about adenoid hypertrophy in children, where it might cause obstructive sleep apnea. So coming to the complications of OSA, this is an important slide because we need to know why we need to evaluate and treat for obstructive sleep apnea. Because patients usually feel it's just snoring, I am not getting aroused or I'm not getting disturbed. Why should I get treated for it, especially with hi-fi stuff like Cpap machines and others? So the complications of obstructive sleep apnea are well known. The first and foremost is an uncontrolled hypertension. Like about 50% of OSA patients have systemic hypertension, which might not be controlled. They might require 2 or 3 medications to control their BP. The physicians will be very aware that the patient might have OSA. When they start treating this OSA, this hypertension also, the medications can be stepped down. Next important thing is rhythm disturbances and heart attacks. The OSA patients are about 4 times more risky to have a heart ailment. Then comes the stroke, where it is almost 2 to 3 times increased risk. Fatty liver disease. Vehicle accident is a very fatal complication where we have seen people sleeping off while driving and even met with an accident. Then the last one is sexual dysfunction, where it is a commonly misattributed symptom where we don't connect sexual dysfunction with an obstructive sleep apnea. Is obstructive sleep apnea that common? Yes, it is a very common disorder and more often goes unnoticed or even gets ignored. People get treated for the complication of OSA and not for the problem per se. That is, OSA doesn't get treated, whereas they get treated for the complications of OSA, which was just dealt. Symptoms get attributed to other comorbidities or lifestyle, like I snore because I sleep deeper than others, which is usually not the case. Now coming to this is just a tip of the iceberg, which I'm trying to depict with a picture, like where 100 people are there, about 10 people have OSA, and out of which 3 people have very severe symptoms affecting their day and other symptoms which was just dealt with. Whereas out of which only 0.3 gets treated for OSA. As you can see, the number is about 10, where the patient who gets appropriate treatment is just 0.3. It is not even 1/10 of the patients. So who should come for evaluation by a sleep physician? Like they might be having snoring, but associated with snoring, they need to pick up certain symptoms which are very subtle, sometimes gets ignored. So loud snorers with sleep disturbance definitely needs attention because it is affecting their sleep, which can be with a daytime sleepiness or less productivity or a daytime fatigue. Next is obese patients with uncontrolled hypertension may be requiring even multiple medication. They just need to rule out OSA, which might be the reason for being uncontrolled. Feeling fatigue during daytime with no obvious explanation. They have some subtle snoring, but patient gets more fatigue during the day or while at work, which even needs evaluation with proper sleep evaluation. Then patients with daytime sleepiness definitely needs why they sleep during the day. One of the reasons could be obstructive sleep apnea.
You're not audible, doctor. I think the slide presentation has stopped. Dr. Rajagopal?
Yes, ma'am.
Okay, I think your slide presentation had some problem towards the end and we couldn't really. Are you done with it?
Yes, ma'am. You want me to, you can tell me if you want.
It was the last slide where it kind of stopped. So everything was written on the screen. So that's fine, I suppose.
That's okay.
Okay, thank you so much for the presentation. And our next panelist is Dr. Abhishek Goyal, who did his DM in Pulmonary and Initial Medicine from the Postgraduate Institute of Medical Education and Research, Chandigarh, and he's currently an additional professor in the Department of Pulmonary Medicine at the All India Institute of Medical Sciences, Bhopal. Dr. Goyal is a recipient of the American Association of Sleep Medicine Fellowship from Cleveland, USA. He established 4-bedded level and 1 sleep labs in AIIMS Bhopal in 2015. He's also a leading author in sleep medicine with over 60 published medical articles. He will give a presentation on what do we do in the sleep labs and what are the various options for obstructive sleep apnea. So over to you, Dr. Abhishek Goyal.
Thank you, ma'am. Is my screen audible? Is my screen visible?
Yeah, it is visible.
Okay. Good afternoon, everyone. As Dr. Rajgopal has mentioned about the sleep apnea, it's a pretty common disease, and we have done a large study in central India where we found that this disease was prevalent in almost 1/3 of the individuals. So this disease is much more prevalent than what we have thought of. And I will tell you about the basic infrastructure, what is required for a sleep lab. We have 2 kind of facilities for diagnosing sleep diseases. One is the in-lab or in-hospital sleep studies, which is we have this kind of infrastructure in which you have a sleeping bed in which the patient sleeps during the night, and there is this technician room where the technician watches the patient throughout the night, what kind of activity the patient is having, what kind of problem the patient is having, and if patient has some disease, then the technician or the doctor start the treatment during the night itself. The another facility is diagnosing in-home sleep testing, which I will be talking about later. So for diagnosis of sleep apnea, we need multiple channels which are applied to a patient's body. These are multiple channels. These look scary, but they are very simple things which are applied on a human body. And it hardly takes 20 to 30 minutes to apply on a person. And it takes around 5 minutes in the morning after the study is complete to remove it. So in the channels, we usually put some nasal cannula in the nose, which is not very uncomfortable. The other thing which we apply is a respiratory belt, which is applied over the chest and over the abdomen of the patient. There is a sensor for measuring snoring, and there is a sensor for measuring saturation. Apart from that, various leads are applied over the scalp of the patient to measure the brain activity to see what kind of sleep stage patient is in, and what kind of whether the patient is having multiple arousals during the sleep or not. So these are type 1 to type 4 kind of studies. Type 1 is the highest kind of polysomnography, that is sleep lab, which is done in the hospital. And level 2, that is type 2 study, can be done in hospital or in home of the patient. And type 3 and type 4 are sleep studies which can be done in the patient's home in their comfortable zone, but they are limited channel sleep studies. So they have their own limitations, but they are more comfortable for the patient and also more cost effective. So this is the image how a patient looks like when he undergoes a level 1 polysomnography. So there are multiple channels which are applied over the scalp. These are applied via glue, which can be easily removed. And there are multiple belts over the thorax, that is over the chest and over the abdomen. There's a saturation probe over the patient. And these channels are applied to a base station connected by a head box, which is applied over the patient's body. This image looks that patient might be undergoing a lot of trauma while applying this kind of leads, but it is not. It usually takes 20 minutes, as I said earlier, and it is very easy for the patient to undergo this kind of test. So there is a saturation probe, which we all, most of us have seen during the COVID era. It is also applied on the patient's finger to measure the level of desaturation, that is low oxygen level going during the sleep, because one of the complications of sleep apnea is that patient has low oxygen during his sleep. So as I told earlier, there are multiple EEG leads which are applied over the patient's head, and these leads are connected to a base station, and then this base station is connected by a wire which is connected to the technician room, where the technician or the doctor sees throughout night what is happening to the patient's body in their sleep. So that is a very laborious kind of process which happens during night, and we usually do 3 to 4 sleep studies in our setup per night, and our technician to patient ratio is 1:2. That is, one technician will apply for 2 patients. One technician will take care of 2 patients. And whenever we are going to have 4 patients, then we have 2 technicians doing the sleep study. For a pediatric sleep patient, the ratio should be 1:1 according to American Academy of Sleep Medicine guidelines. That is, for pediatric patient, the ratio of technician to patient should be 1:1. That is, when we have 1 patient, 1 pediatric patient, then 1 technician should be there. So our technical staff remains awake during night. During whole night, they remain awake to see the activities going on in the patient's brain. And if the patient is having some disease, then they, according to the guidelines, they start treatment if it is required for that particular patient. Another level study is level 3 or level 4 polysomnography study, which is also known as home sleep testing, HST, which is done in the comfort zone of the patient. As I mentioned, it is very cost effective because it is less costly for the patient. The machine is less costly. As I mentioned, the level 1 polysomnography machine, the cost of establishing 1 level polysomnography machine is around 20 lakh Indian rupees, whereas the cost of a level 3 polysomnography machine is hardly 1.5 lakh rupees. So it is easier and it is cheaper for the patients to undergo this kind of home sleep testing. But in this home sleep test, there are only 3 channels. One is a sleep saturation monitor, which is applied on the finger. One is a thoracic belt applied on the chest, and one is a nasal cannula to see the amount of air going inside the patient's windpipe. But because patient does not have multiple channels, so we have limited data which is available, but it is usually sufficient for around 50 to 60% of the patients who undergo home sleep testing. When patients are having clear-cut patient of sleep apnea, that is, they are very obese and they don't have any cardiac complication, they don't have any neurological complication, then the patients can easily undergo this kind of home sleep testing, and then we can start auto Cpap machine therapy if the patient fits into the definition of sleep apnea. But as we don't have multiple channels, then there is a fallacy to this kind of home sleep testing, that we cannot diagnose other sleep disorders. We cannot use this kind of testing in patients with cardiac disorders. We cannot use this testing in patients with associated neurological disorders. Also, we cannot start therapy during night, which we can in the settings of in lab or hospital testing. So how does the apnea or hypopnea looks like? I will just show by pictures just to show what happens during night is, as Dr. Rajgopalan showed in his video, that the airflow decreases, and as the airflow decreases, the saturation also goes down in a human's body. So this process continuously goes on throughout the patient's sleep. It is almost like someone is choking the patient in his sleep for few seconds. Then again, the patient is taking breath. Again, this process of choking goes on. This process goes on continuously. So this is a kind of chronic process which goes whenever patient goes to sleep. And this low level of oxygen which happens in a patient's body leads to a lot of cardiovascular complication, which was mentioned in the previous PowerPoint presentation. So earlier it was an apnea. This is the apnea, and as the flow is absolutely going down, and this is hypopnea, in which the flow is going down slightly, but it is significant enough to cause cardiovascular or heart problems. So we define severity of sleep apnea on the basis of a score which is known as apnea hypopnea index. It is a crude method. It is not the perfect method, but it is the method which is available currently. And on the basis of this, we define the severity of the disease. If this is the number of times a patient stops breathing during his sleep per hour. So if a patient stops breathing more than 5 times per hour, then it fulfills the criteria, the current definition of sleep apnea. But the treatment, currently it is described only for patient more than 15. That is, if patient is stopping breathing more than 15 times per hour, that is every 4 minutes, if patient is stopping breathing, then patient fulfills the criteria of starting the treatment. So as I mentioned, there are 2 kinds of sleep testing facilities. One is in hospital, one is in lab. So in lab is always better than in hospital. In lab is always better than in home testing, because we have multiple channels like EEG, we have snoring sensor, we have multiple channels which we can see the patient sleep in totality. So it is easier for the doctor to diagnose, to treat with confidence. Whereas in case of home sleep testing, we are able to diagnose for most of the patient but the certainty, the confidence level is not as good as it is there in level 1. But as it is very it is very laborious process. It is costly to establish a level 1 polysomnography machine. So most of the places, level 3 or home sleep testing machine diagnosis is being done, and it is considered okay from a third world country point of view, and considering the number of patients we have who require the treatment for sleep apnea. In the state of Madhya Pradesh, where I work, we have only 5 level 1 polysomnography machine. Out of those 5, 4 are in our hospital. So with a population of 8 crore in Madhya Pradesh, we have only 5 level 1 polysomnography machine, and level 3 polysomnography machines are around 20 in our state, and which caters to the huge population, which is also very insufficient. But as in a practical way, we can triage our patients who will require home sleep testing and who will require a level 1 polysomnography machine. This is the kind of picture the technician and the doctors are looking throughout the sleep. It is very difficult for a novice to interpret this, and it takes around 3 to 6 months to get trained in the kind of testing, the training of sleep technician. So there are few courses in India which are available for diagnosis of sleep technician, and there are very limited courses for training of sleep doctors. So we have a limitation of sleep doctors and sleep technician in our country, which is also one of the major important factors why level 3 or home sleep testing machines are being favored, because we don't have technicians or doctors to interpret and manage level 1 polysomnography or sleep labs in hospital. So coming to treatment, there are various modalities of treatment. The most effective or the gold standard is positive airway pressure, which is a kind of machine which is applied, which delivers pressure under air. As Dr. Rajgopalan said, that there is a narrowing in the most narrowed part during sleep, and this area further narrows down in patients of sleep apnea. So what this machine does is that it pushes air under pressure and it keeps this airway patent. The job of the doctor, the technician overnight, watching the disease overnight in sleep lab, is to determine what kind of machine patient requires and what kind of pressure the patient requires. The pressure for the machine starts from 4 centimeters of water up to 30 centimeters of water. So that entirely depends upon the severity of the patient. It depends upon the type of sleep apnea. Patient might have only obstructive sleep apnea. Patient might have central sleep apnea, which is an entirely different topic and a difficult disease to treat. Then the most effective option among this positive air pressure is Cpap. We have all other options like auto titrating PAP, which is an automatic machine. And usually it is thought that automatic machine will be better than a continuous PAP, which is far from reality. Automatic machines are costly. They work in a particular subset of patients. They are not very effective in patients who have cardiac disease, and they cannot be given in patients with associated cardiac disease like heart failure, like stroke, and in patient with central sleep apnea, it is not recommended at all. In patient associated with coronary disease as well as COPD, that is chronic obstructive pulmonary disease, auto-titrated PAP machines are contraindicated, that they cannot be given. The other option is bi-level PAP, which is an advanced mode of continuous PAP. This machine is given when the patient does not get titrated well with a CPAP machine, then we give BiPAP. We also have few modes in that. So it is a complex kind of medicine, which is still in infancy in India. This machine was invented in 1981 by Sullivan. And after that, we have many machines with many algorithms which are proprietary of the companies who are making that. So it has made this medicine a very evolving field, and this leads very good amount of research is required as far as our country is concerned, because in India as well as in Mongolian population, the phase structure is very narrowed. So this, because of narrowed phase structure, the crowding is very much, and we cannot follow the guidelines or the treatment protocols of a Caucasian population. So we need to have our own research protocols, our own therapy, and we cannot use the protocols followed in the Western population. So these are the kind of masks which are applied for patient. These are nasal masks. This is also a nasal mask. This is a oronasal mask. So the type of mask depends upon the severity of the patient's disease, the amount of mouth breathing, and the the amount of pressure which is required for a patient. Most often, nasal mask is preferred for the patient, but sometimes oronasal mask has to be given to a patient during titration. Sometimes CPAP is not the only option available for patients in mild to moderate kind of disease. We can advise patient weight loss. Patient should not drink alcohol because it further decreases the tone of the muscle, and tobacco and sedative should be avoided. If hypothyroidism is there, it should be treated. And most common, the type of obstructive sleep apnea is supine positional sleep apnea, which is highly prevalent in an Indian population. For isolated positional sleep apnea patient, advising only positional therapy is sufficient, but this can only be determined only after doing a polysomnography machine in hospital, so that we can have a video recording, that we can see whether the patient is sleeping in lateral position and patient having less severe disease, and whether the patient requires actual treatment or only position therapy will be sufficient for the patient. So sometimes there is a very common question that since this disease is associated with weight gain, so whether weight loss will be sufficient for the patient. So actually weight loss is very easy to advise for doctors, but it is very difficult to do for the patients. Even to reduce 5-6 kgs is very difficult task, considering if your sleep quality is not good, then the difficulty in losing sleep is very much, because sleep plays a very important role in weight homeostasis, that is weight balance. If the sleep quality is impaired or sleep quantity is less, then how much exercise the patient does, the amount of weight reduction is very insufficient. So weight reduction can obviously help, but that can not only be advised to a patient having severe disease. That can be advised to a patient with mild to moderate disease, and it will lead to decrease in severity of sleep apnea, but it will not be sufficient. Suppose a patient is having very severe disease, his sleep apnea severity is around 60, which is more than the 30 cutoff criteria of severe. If the patient reduces the weight even by 10 kgs, then the severity will reduce by only 15 to 20%. Even then the patient will be in severe category. So only losing weight should not be a treatment option for very severe patients. It should be advised for all patients, but that should not be the only treatment for patients with severe disease. Apart from this weight reduction, position therapy, CPAP, we have some oral devices also. These devices can be given in young, thin individuals with good oral structure if they have retrognathia, but their jaw abnormality is not there. Apart from retrognathia, these devices can be given. These devices pull the mandible forward, creating space in the retroglossal, that is behind the tongue area. But these also have their own problem. They can be given in only mild disease patient. They are very costly. We don't have dedicated dental sleep specialists to make this customizable devices. The online available devices do not work that well, and this causes jaw pain. And most of the patient usually loses interest because of this jaw pain side effect. So they are very less percentage of patient who can be readily treated by these kind of devices. Another thing is surgeries, and there are a lot of many surgeries which are being done. I will be enumerating only maxillomandibular advancement because it is the only surgery which has shown some good results in patient with retrognathia, that is in patient with small jaw. What happens in this patient is, when the patient is having retrognathia, small jaw, or the tongue, the jaw which is behind the line which is required, it causes the narrowing of the airway. And in the surgery, what the dental surgeon does is they cut the mandible and the maxilla, they bring it forward, creating a lot of space behind the glossal area. But we have seen that in few studies which were done in Indian population, that in Indian population this surgery may not work very well. We can say whether this surgery will work only after doing a drug-induced sleep endoscopy, which itself is not available at most of the places. So if patient is having very severe kind of jaw abnormalities, then maxillomandibular advancement can be done by a good and trained dental surgeon. So we have many myths associated with this sleep disease, sleep apnea, that weight loss can cure it. As I mentioned, weight loss cannot cure it. It can certainly decrease the severity. And for most of the patients who come to us in our clinic, they have very severe sleep apnea disease. And we always advise them weight loss, but along with other therapies, most commonly CPAP is advised. As Dr. Marajpal has mentioned, that it is not a benign disease. It has got a lot of complications. We also think that this is a disease of West. We are in a stage of completion of a very large study, as I mentioned, and the population prevalence in a normal healthy individual got around 30%. That is, every 1/3 of individual have this disease. So this is not a disease which is uncommon in India. Earlier, we used to think that diabetes is very uncommon. 40 years back, it was thought that cancer is not prevalent in India. As we are gathering data, it is seen that we are not immune from this disease. We also have a high prevalence of sleep apnea, and probably this prevalence is significantly higher than that of Caucasian population. And usually snoring is there, and it is the pathognomic sign which is seen in 95% of the individuals, but in children and in very elderly individuals, snoring may not be there. So we have to be very alert if patient is presenting with some typical symptoms in absence of snoring in extremes of ages, then we should be suspicious whether sleep apnea can be there. And hypersomnia, that is excessive sleepiness, is not the only complaint. 30% of the patients usually present with excessive sleep. 30% patient of sleep apnea usually present with insomnia, and 40% do not have any complaint of sleep at all. They usually present with hypertension, with coronary artery disease or stroke. They present with complication in absence of any sleep complaints. So as a sleep physician, we should be vigilant in which patient should be screened for sleep apnea. And it is a field, as I said, which is very evolving. It is in infancy in India. We need good trained doctors and technicians to in different part of the country, so that we can have more established level 1 and level 2 labs. As I said, level 3 labs are available in most part of the India, but it is insufficient in 40 to 50% of the individuals. Thank you from my side. Thank you.
Thank you, Dr. Goyal, for that very nice and long explanation indeed of the disorder, and all those slides which you showed us of wired up individuals with masks and devices were a tad scary too. We finally move on to our third and final panelist for the morning, Dr. Niranjana Sridevi. She completed her MBBS from the Government Medical College Thrissur in Kerala and MD in Geriatrics from Christian Medical College, Vellore. She's now working as consultant in geriatrics and internal medicine at Nairobi Hospital, Vellore. With nearly a decade's experience, her areas of special interest include managing lifestyle diseases which lead to healthy aging. Warm welcome to you, Dr. Niranjana, and over to you.
Thank you, ma'am. My slides are visible, right, ma'am?
Yes, yeah.
Okay. So good afternoon. I will be talking about obesity. So, what is obesity? When we define obesity, it is a state of excess adipose tissue or fat tissue mass. So it means an increase in body weight, but that need not be the case every time, because there can be muscular people who will be obese or overweight by the standard measurements, but they need not have adiposity. It is a chronic problem which is increasing in prevalence, and it is a global epidemic. So what causes obesity? The body weight is regulated by a complex system which involves many neural and hormonal pathways. And finally, you can see there is an imbalance between the energy intake and energy expenditure, which results in obesity. So these are the few causes. The main cause is the dietary habits, the frequency of eating high-calorie diets, overeating. Then some social and behavioral factors like ethnicity, night eating, binge eating, sedentary lifestyle, which decreases the energy expenditure, which is very common in aging, post-operative period. Then there are some medical causes like some drugs, corticosteroids, some psychiatric medicine, some medical conditions like hypothyroidism, Cushing's disease, and there is a genetic predisposition which causes obesity. How do you measure obesity? BMI or body mass index, which is the most common tool we use. It's a simple calculation. You measure your weight in kilogram and height in meter and you get a value. Based on that, you can say whether you are obese or a overweight person. Other is to measure your waist circumference. This is important because the location of the fat in your body is an independent risk factor, like abdominal obesity, intra-abdominal and subcutaneous fat around the abdomen is linked to most of the complications of obesity. That's why the waist circumference is important. This is the normal BMI values. It's 18.5 to 24.9 is the normal. Above 25 is overweight, above 30 is obese. But these are for the Western people. In Asian population, the previous BMI cutoff actually underestimates the risk of obesity. So for Asian population, overweight means BMI between 23 and 24.9, and obesity means BMI above 25. This is the waist circumference. The cutoff is 40 inches in males and 35 inches in females. But it is the cutoff in Asian population is even lower. 35 inches or 90 centimeter in males and 80 centimeter in females. What are the health consequences of obesity? Obesity is significantly associated with excess mortality and morbidity. If you can count, there are over 230 comorbidities associated with obesity. This slide shows some of the comorbidities I have highlighted, which is the common what we know: diabetes, hypertension, cholesterol, heart disease, and the topic of today's discussion, obstructive sleep apnea. I will be stressing on the management of obesity. So when you manage obesity, there is lifestyle intervention, which is the first and very easily what we can do at home. And if that obesity is not getting controlled, then we go into the subsequent treatment, which includes drugs, devices, and surgery. The comprehensive lifestyle intervention. So obesity is fundamentally, there is a disease of energy imbalance. The intake is more and expenditure is less. So every person should know how and when energy is consumed. That is what diet is. And how and when energy is expended. That is the physical activity of each person. And how to incorporate this information into our daily life. That is the behavioral therapy. So coming to the diet, if you ask me, there is no one single diet that fits everyone. And the most important goal of a dietary therapy is to reduce the total calories consumed. So whatever diet you follow, you find how much calories you are eating. If you can reduce that, that is a very good diet. And another important thing, dietary adherence. This is the most important part. Whatever diet you follow, you have to follow that diet. Because obesity is a chronic problem. Following the diet for a short term might not help you. So some general tips about the diet. You can choose a smaller portion of size, eat more fruits, vegetables, choose whole grain cereals instead of refined food, choose leaner cuts of meat, skim dairy products, then reduce the fried items or the food items which has added fats or oil. And when you're thirsty, drink water instead of going for a juice or a carbonated drink. Another concept is to choose low energy density food because they add to the volume of the food you eat that can cause satiety. The examples include soups, vegetables, fruits, oatmeal. These are few types of diets which is available, like a Mediterranean diet, DASH diet, low fat diet, high protein diet, very low calorie diet. This is a Mediterranean diet. Basically, they advise very high consumption of plant-based products like fruits, nuts, vegetables, whole wheat cereals, and a moderate consumption of dairy and milk products, and a very low consumption of meat. Wine in moderation is recommended, and you drink a lot of water. The DASH diet, which is also recommended, it's also a similar diet. They are recommending to take 4 to 5 servings of vegetables, fruits, and 2 to 3 servings of low-fat dairy. Now coming to the exercise. Physical inactivity is linked to obesity. So when you are very active, you will not gain weight, but the reverse is not always true. Exercise alone is only moderately effective for weight loss. But still we recommend exercise because it is important to maintain your weight loss and to prevent further gain and to improve your cardiorespiratory fitness. But exercise as per alone will not cause much weight loss. The next is the behavior therapy, the diet and exercise, how to make that a part of your life. So some tips I would like to share. One is to set goals. There should be weight goals and behavior goals. The weight reduction goals should be realistic, like 1 kg weight loss in a week or 5% weight loss in 6 months. You set goals. Then self-monitor. You keep diaries about food diaries, activity trackers. You monitor your weight daily. That will help you to keep track of all these things. Next is the stimulus control. Stimulus controls means there are some triggers in the environment where you eat more food, like watching TV, while traveling in a car, while when you're in dining table, you eat food and then you are reading something or watching your mobile. So take note of this stimulus and try to avoid these things. Next is the eating style. It's called a mindful eating. When you eat slowly. You enjoy the texture, the content of the food. When you're eating very slowly, the physiological mechanism which produces satiety comes into setting. That way, the amount of food you eat will be reduced. Then regularly weigh. Have a weighing machine at your home. Regularly weigh and record your weight. Then plan your meal beforehand and control the portion, how much you eat, and increase your physical activity. These are the behavioral things you can do to help you in weight loss. When all these lifestyle measures are not adequate for weight loss, then you can have a consultation with the doctor. And there are few drugs, other drugs, devices of surgery, which help you in weight reduction. So for when we prescribe drugs, the candidates selected are based on their BMI more than 30, or even a lower BMI more than 27 with a complication. We can prescribe drugs. There are two groups of drugs. One will suppress the appetite. Other is gastrointestinal fat blockers. These are the examples of the drugs we usually prescribe. Of this, the first one, liraglutide and semaglutide. These are injections, once daily or once weekly. When used, up to 7 to 8 kg weight loss can be achieved over a year. And the last one, the orlistat, is a drug which alters the fat digestion. Then there are devices. Devices are recommended when this lifestyle intervention is not much effective and medications are not tolerated. And this is also like a bridge therapy before bariatric surgery. The examples include laparoscopic adjustable gastric banding, intragastric balloon systems, or hydrogels or pills you can take along with your meals. These are all temporary, like you use it for 6 months and reduce the weight, and then they can be removed. Finally, the treatment is the bariatric surgery. This is recommended for people who are very obese, BMI more than 40 or BMI more than 35 with complications. The weight reduction achieved through bariatric surgery is very significant. Up to 40% weight reduction can be achieved. And another thing is you can maintain that weight loss. All other lifestyle intervention drugs or the devices, once you remove those things, the people can again regain their weight. But this is a permanent solution. So you can see these are the various procedures done in bariatric surgery. They restrict the amount of the, mechanism is restriction and malabsorption. So the amount of food the stomach can hold will be reduced. By that way, your the food will be reduced and you eventually lose weight up to 40 kgs in over 1 or 2 years. So these are the methods you can reduce the obesity. So I hope everybody starts acting and become healthy. Thank you.
Thank you, doctors, for all your informative presentations. And to our audience, the Q&A box is open. You could direct your questions to the specific doctors. Meanwhile, Dr. Rajagopal, I would like to ask you, since the focus of the last presentation was on obesity. So are children also getting affected by sleep apnea, given the fact that childhood obesity is a cause of major concern today? Your audio, doctor. Audio.
Yes. Now, am I audible, ma'am?
Yeah.
Yeah.
Could you hear me? Could you hear the question?
Yes, ma'am. I could hear it about childhood sleep disorders, right?
Yeah, right.
Yeah. So usually, sleep apnea, even in adults, is being ignored and being undertreated. Leave alone pediatrics. Pediatric sleep disorders are also common, which gets ignored more often. And like you said, childhood obesity is also common. So childhood sleep apneas are also common. Most commonly in childhood, the difference between adult is usually there will be an anatomic problem like tonsil or an adenoid hypertrophy where they need corrections to treat it. So that's the usual difference between an adult and children. But like you said, it's being ignored and also needs attention.
And like, are men and women equally vulnerable? Which is like most kind of the age category wise, which is the most at risk group?
Okay, elderly people, like as the age progresses, there is more risk of getting an obstructive sleep apnea. But unfortunately, males are more prone because of their anatomic as well as excessive weight more than females. Males are more commonly affected by obstructive sleep apnea.
Right. So we've already got lots of questions. Majority of them just want to know one basic simple thing is, how do I get a sound sleep? How do I sleep without disturbance for 8 hours? Who would like to take that? Dr. Abhishek, Dr. Rajagopal?
That is a very difficult question to answer. So actually sleep
your audio, Dr. Goyal.
I think my audio is okay.
Yeah.
So it is a very difficult question that how to sleep soundfully. It is in nowadays it is a luxury to sleep for 8 hours. It was nature made us to sleep for at least 8 hours, and humans are the only primates which sleep for 1/3 of their life. Most of the primates, they sleep for more than 12 hours. So we have been made by nature to sleep for at least 8 hours, and because of the busy schedule, we are not sleeping even that. So as our sleep depth increases, then there is bound to have complications. So one thing is to have a good sleep is to be away from the screen. The screen emits blue light, which is very harmful for the brain, and which leads to difficulty in getting a sound sleep, deep sleep. So the guidelines mention that we should be away from our screens, that is, be it TV, mobile, laptop, anything which emits light. We should be away from that at least 2 hours before our sleep. One is that. Second thing is we should not have heavy meals before our sleep. There should be a gap of at least 2 hours between sleep and and dinner. And we should not have our take too much of water before sleep, because most of the patients who have difficulty in sleep, they have nocturnal urination problem. We should be away from caffeine, which is very difficult. Another addiction in our society is that we take around 4 to 5 cups of tea or coffee in a day, which leads to stimulation of the brain. So the sleep purist says that we should not have our last cup of tea or coffee after 2 p.m. in afternoon if you want to have a good night of sleep, which I don't follow. So it is very difficult to say that what is the goal, the mantra for a good night 8 hours sleep. But we should be away from the addictions of sleep, of the screens, of the caffeine, and definitely we should lose weight if the patient is overweight. That is very important. And if patient is sleeping in a room with TV, which is very common also, the TV should never be in a patient's bedroom. If patient is having difficulty in sleeping, he is having insomnia problem, wall clock should also be removed from the wall. And if patient thinks that he is not feeling sleepy even after lying down for 15-20 minutes in bed, then he or she should get away from the bed. He should do some mundane activity like reading or doing some boring activity. He should not do any activity which will activate his brain. So after a few minutes, then again he should go and try to sleep. But if he is not getting sleep even after 20 minutes on lying down on bed, then again he should do some activity. And again, if insomnia is there, I think this question pertains to insomnia, not to hypersomnia. If patient is having difficulty in getting sleep, he should have a regular sleeping pattern, which is the most important thing. So he should go to sleep at particular time. The nature has made human body to sleep between 9:30 to 10:30. The farther we sleep from this time period, the more difficult it becomes for our body to get a good amount of sleep. If someone is sleeping at 11 o'clock or 12 o'clock during weekdays, and on weekends they try to sleep at 1 o'clock, which is a very normal habit, and try to get up later, the brain has to reboot itself on Monday, and it becomes a chronic habit that on Monday he has to get up at 6 o'clock or 7 o'clock, and on Sunday he's getting up at 10 o'clock. So we should have a very fixed schedule to have a good amount of sleep. Although we can cover up our sleep depth to some extent on weekends, but it is not recommended.
Right. I think we all are guilty of such habits, and we need to work on our sleeping habits. Dr. Rajagopal, like in your presentation, you also mentioned about, loud snoring, which is also one of the major indicators of sleep apnea. But somebody is writing that not everyone who has sleep apnea snores. So how does one gauge that, we need a visit to the doctor? Somebody may be living alone and may not be realizing that he or she is snoring, or somebody gets up with a fatigued feeling in the morning, which could be kind of an overlapping symptom of so many other ailments and could be attributed to other health issues as well. So like when to take that call of, seeking a doctor's intervention?
Yeah, snoring is the most prominent symptom we usually together, like the bed partner, whoever is their wife or the mother or the brother, usually sees the patient snore a lot. So they bring the patient to the attention of the doctor that the patient snores a lot. I am not sure what's happening. So that is the most common thing that, like you said, if someone is sleeping alone and if he is not getting affected by the snore, then if at all he is having daytime symptoms like fatigue, which is unexplained, he has no other chronic illnesses that can cause fatigue. And during the daytime, he is sleeping at inappropriate places, which means like you shouldn't sleep. Like while driving, if you're feeling sleepy, it means that even when you're trying to be awake or active, your brain dozes off. That's what it means. That's the highest level which we can usually see. And in people working in like very risky environments, like with high-end machineries, also try to be awake, but then sleep off if they're having a problem. So the main attention would be this. And the other part of the side is like, if the patient has uncontrolled hypertension, even if with best medications and appropriate adherence to medication, the patient is not having an hypertension that is getting controlled, or a patient with heart failure has even subtle snoring, needs evaluation. So the main symptom would be loud snoring, but it is not the only symptom. There are other subtler symptoms which can be picked up only by the doctor. So it's better to get, even if they have a small doubt, better to have a consultation with the doctor so that they'll be able to decide how to proceed further.
So Mr. Subramaniam has kind of a contradictory situation. He says, I am in my 50s and I sleep very well I get good sound 7 hours sleep, but my family tells me that I snore. So should I kind of go for a OSA checkup? Dr. Rajagopal or Dr. Abhishek?
Right.
Hello, can you hear me?
Yeah, I can.
Yeah. So like I said, the snoring is picked up by others, whereas the symptoms that affect the patient might be very subtle. So he definitely needs it. But the problem is like someone who snores, unless there are other triggering events to get a consultation, they get very less motivated to see a doctor for such things. It is like, I snore, but I don't get disturbed. Why should I do something? So it's like that. But it is better to get evaluated, and the doctor will be able to pick up subtler symptoms or other comorbidities by simple interview. They'll be able to pick up. So it is better to get a consultation. But a sleep study is required or not is depending on the patient's condition and the evaluation which is being done.
Dr. Niranjana, Mr. Ganapati Bhatt wants to know, can pranayama, asanas, and deep breathing techniques help to kind of firefight OSA?
Ma'am, exercise per se, that is what? Exercise per se is not for a weight reduction. So, but to improve your cardiorespiratory fitness, all these things helps you. And when people lose their weight, the muscle mass also will be lost. So whatever exercise do will build up your muscle mass. Like that, with that your BMR will increase. That will help you to remain fit and healthy. But weight loss is not a target in this. And in OSA, they want the main treatment is they would want a weight loss. And if it is not controlled with the weight loss, then they will need evaluation and the treatment for that.
Dr. Abhishek Prahalatan wants to know, are there CPAP machines that are suitable for overnight travel with a battery backup?
There are few machines available. One has been launched 2 years back by ResMed, which is a very portable kind of machine, which weighs around 500 grams. And it is an auto CPAP machine. It does not deliver a fixed kind of pressure. It can be used for short durations, but that should not be the routine machine which should be used for most of the nights. It can be used during the travel because they have their own limitations.
Dr. Rajagopal, Debashish Gupta is asking, can a patient get admitted for OSA assessment and treatment at Nairobi Hospital under Mediclaim coverage? Dr. Rajagopal, are you there?
Can you hear me, ma'am?
Yeah.
Yeah. So that's a very nice question. But the only problem with Indian insurance companies is that they don't cover anything related to sleep. And unfortunately, we have seen certain patients even get admitted for a very emergency condition. They have respiratory failure, which means that their oxygen level is low or their carbon dioxide levels are high because of the sleep condition. They're not getting covered in insurances. So it's very difficult to cover for it during insurance. And if the patient even has other comorbidities, they don't cover and leave alone OSA for that. That's very unfortunate in our country as such, which is very contrasting from the West, where everything from the first step till the last step gets covered by insurance, and the acceptance increases because the machines which we are dealing about are a little bit costly for most of the population in India.
Dr. Niranjana, Mr. Balakrishna Pisupati has a problem of breathing with open mouth. He says he has also developed panting recently. So is it related to OSA and should he be seeking a doctor's consultation?
Ma'am, I think he should meet a doctor. I am not able to conclude. I'm not able to understand the symptom, ma'am.
Okay, because a lot of people have actually written with their personal complaints, and everybody wants to know whether OSA can be just controlled with medicines. Or, in fact, Dr. Abhishek, like you mentioned about maybe there not being an adequate number of sleep labs in the country. So somebody also wants to know what is the cost of kind of visiting such a sleep lab and getting yourself.
I work in a government hospital setting, so our cost is very minimal. But most of the private center in India, they charge somewhere around 10 to 15,000 rupees for a diagnostic study. And if they are doing the treatment as well as diagnostic, the charge is roughly around 15,000. I think Dr. Rajgopal will be in a better position because he's working in private setup. But the main issue is that we don't have a good number of trained physicians. I think in the state of Tamil Nadu, I don't think there are more than 3 or 4 sleep level 1 polypharmacy labs in even a state which is more advanced as compared to the state of Madhya Pradesh. So in terms of health facility, that's right. So we have a scarcity of trained physicians and facilities because they are very costly to establish, even in a private setup. So as the cost you asked, that is around 10 to 15,000 in a private setup. And in a home sleep testing, the cost is 3 to 4,000 rupees for most of the places. But as I mentioned in my lecture, it is sufficient for 50 to 60% of the clear-cut OSA patients. If patient has anything related to cardiac heart failure, or patient had a stroke, means paralysis have been there in patient history, or some complicated patient is there, then the home sleep testing should not be done.
Dr. Rajgopal, would you like to add to that? Yes, ma'am. Like sir said, sir is working in AIIMS, so it will be easy. As he's saying, it's very minimal. Whereas in a private sector, like sir said, it's around, you can assume somewhere between 7 to 10,000 for a diagnostic study, which means not the level 1, which is very difficult. Maybe the level 2 or 3, where it is easy to perform, is between 7 to 10,000. And the second step, the titration study, if required, might be costing around 5 to 6,000. So that is the approximate amount that might be required for the diagnosis and the treatment initiation part. Whereas the machine cost will be somewhere like standard machines, like we have in phones like Apples and Samsung. Same way, the machines are multiple companies are coming in, but a standard machine would be costing around 40 to 50,000 at least, and they can be even taken for rent. Which may be around 3 to 4,000 per month, which usually we don't suggest because they have to use it for at least we don't know how long they're going to use. And if they use it even for 6 to 7 months, the whole cost of the machine will be actually got back. So this is the usual cost that is in a private setting.
There are a lot of questions from our geriatric listeners, but I would just randomly pick up one because they read similar. So somebody is writing that my mother-in-law is 70 years and she weighs around 88 kilos. She snores during sleep. So at her age, with her diabetes and hypertension, so maybe she's not in a position to do enough exercise or even go on the kind of diet recommended. So what should be your advice to her, Dr. Niranjana? There are a lot of similar questions from, people who are above 60, 70, 75 years old.
Exercise helps in all ages. See, if they are like very old, we can do like weight training, like sitting in the chair or lying in the bed. We can do some stretching exercises, because at any age, if the patient can do it, if there are no contraindications, that will help in improving their fitness. And diet also, as they age, their dietary restriction will be there due to their multiple problems. And in the aging group, the obesity will be because of the inactivity. So I would recommend doing some exercises, and if there are like some comorbidities will be there, take care of that comorbidities. I told you some drugs will cause. So sometimes we will modify their medications according to the patient. So this is what my recommendation is. Even if it's age also, some exercise that is for the fitness of the patient.
There are a couple of questions on, the role of sleeping pills, whether people should take sleeping pills to induce sleep, or whether they should have hot milk before going to bed. Do all these things help?
Actually, sleeping pills, even in OSA, sedatives are not recommended. Elderly especially, one thing is the problems of night when they go to bathroom or something, there is a high risk of fall, and the next day they can have dizziness, giddiness, all those side effects are there. And per se, OSA also, when you give a sedative, I think Dr. Rajagopal and Dr. Abhishek were saying that might worsen that obstruction. So from that perspective, also sedatives are not recommended. But sometimes we do prescribe. So some low dose or other techniques like sleep techniques are there, sleep hygiene techniques are there. We try with that. If that is not working, then we end up in giving. So for some patients, selected patients, we end up in giving sleeping pills.
Dr. Abhishek, there are a lot of questions about the usage of CPAP machine, and people are writing that they are not always comfortable using those machines. And so what would be your advice to them?
So most of the places, the patients are being given an auto CPAP prescription. So as I mentioned, it works only in 50 to 60% of the individuals. Rest 40% patients in our settings will not have benefit. We have published few papers in which it was shown that patients who were given CPAP were not getting benefit, so they had to move to a higher machine, that is bi-level PAP, which I mentioned. It is a costlier machine and which more advanced pressure with more complicated algorithms. So some patients who do not get benefit with CPAP or are feeling uncomfortable with CPAP, they should undergo a hospital lab titration, because they might be having more severe disease, or they might be having some complicated disease associated with that, which might need a different kind of pressure. And sometimes auto CPAP can also precipitate these kind of events, and patient might feel that I am having more difficulty with this machine rather than I am more comfortable without the machine than using this machine. So this kind of patient should always undergo a hospital titration, which is mandatory. And there are n number of papers which have shown that these patients actually requires a different machine, a different settings. And auto CPAP is the only prescription we get in our country because of unavailability of sleep labs.
Right. I think we have really overshot our time. I'll take one last question, which reads very interesting. Dr. Rajagopal, if you would like to answer it. Mr. Arvind writes that I get apnea while I am awake. So is it different from sleep apnea? Dr. Rajagopal?
You're able to hear now?
Yes.
So apnea during awake state is nothing related to what we are dealing today, but he needs evaluation if he is really having an apnea during his awake state. Definitely what we are dealing out is only in sleep, because normally during awake, our brain is already active in giving all the signals to the muscles to keep the airway open. which is usually not the case with OSA, where it happens only at night. He definitely needs thing, because he himself has told that he is having apnea, which I little doubt whether it is really apnea or something else. Should be something else, ma'am. But he needs attention if he's really affecting his day-to-day activities.
Right. I wish I could squeeze in more questions. There are lots and lots of them, and a lot of people want to connect with you directly. A lot of people want your presentations. So maybe the Hindu events team could look into it. And I would really like to thank all you doctors for sparing your valuable time on a Sunday morning. And many, many thanks to our audience which participated and sent in their questions. So thank you once again for joining this wellness webinar presented to you by the Hindu and the Nairobi Hospitals, Vellore. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
Thank you.